This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by.
Welcome to today's meeting of the Fire Committee. On our agenda today is a discussion on the risk of firefighters' exposure to contaminants and its impact on their health and well-being. Before we begin, we have a few small items of business. Please may I remind participants to silence your devices. Members of the public may like to follow at London Assembly on social media and use the hashtag AssemblyFire for this meeting. Can I ask our clerk, Diane Richards, to confirm any apologies for today's meeting?
Thank you, Chair. No apologies for absence have been received for today's meeting.
Thank you. We can now move to declarations of interest. Can we note the list of offices held by Assembly members? And can I also ask members if they have any disclosable pecuniary interests in specific items listed on the agenda? Thank you very much. Can we confirm the minutes of a meeting held on the 1st of July 2025? Thank you. Can we note the completed and outstanding actions arising from previous meetings of the committee and the additional correspondence sent and received? Thank you. Can we note the actions taken by me as chair under delegated authority in consultation with party group lead members, namely to agree the committee's letter to the Mayor of London regarding arson offences in London and the committee's letters to the London Fire Commissioner and the Deputy Mayor for Planning, Regeneration and the Fire Service on key priorities for the London Fire Commissioner? Thank you. We can now move on to our main item, a discussion on the risk of firefighters' exposure to contaminants and its impact on their health and well-being. Can I welcome our guests today? Joining us in the chamber, we have Professor Anna Steck, Professor in Fire Chemistry and Toxicity, University of Lancashire, welcome, and Dr. Johanna Feary, Academic Consultant in Occupational Lung Disease, welcome also. Joining us online on a very early morning, we have Dr. Alberto Caban Martinez, Professor of Public Health Sciences, Miller School of Medicine and Deputy Director of the Firefighter Cancer Initiative. Welcome, Dr. Alberto. And we've got Luke Gazzard, Assistant Chief Fire Officer for Service Delivery, Avon Fire and Rescue Service, and National Fire Chiefs Council Contaminants Group. Welcome to you all. I'm going to start with the first question for everyone. I'll start with you, Professor Anna, if that's okay. How well understood are the routes and mechanisms of firefighters' exposure to contaminants?
I would say...
Could I just get you to pop your mic on?
Yeah, I think... I switch on mic, Ran.
It's a little button. Just. Oh,
Yep.
It is on.
Apologies.
on.
Now they're probably just taking this out.
Got it.
Thank you.
Hello, can you hear me? Yep. Right. I would say they are well recognized in terms of the exposure. So we know that in terms of firefighters' exposure, it's not only inhalation, but it's also dermal absorption through the skin and digestion. I think the difficulty is that obviously fire generates thousands of chemicals, and identifying that specific chemical with the firefight exposure would be a little bit difficult because our testing for the chemicals is only linked to the chemicals we are aware, and we've got methodologies developed. So we do not know, for example, for the novel chemicals, that are introduced to different products that they might pose any health outcomes that might damage firefighter health. I think that's linked really well to lack of the fire toxicity regulation. We've got fire effluent regulations for the transportation, so such as ship, trains, or planes, but we do not have regulation, for example, for building products. So therefore, if we've got man-made chemicals added to the product, for example, perfluorinated chemicals, PFAS, or gas-phase halogenated flame retardants, they might change chemistry and also concentrations of chemicals that are released, and then have direct effects on the firefighter health.
Thank you very much. Dr. Johanna.
So I probably am not an expert on this, so I'll probably pass over to... Sorry. My expertise is not in the exposure and the constituents of fire chemicals, so I'll pass over to other experts on that.
Okay, thank you very much. I appreciate it. Going online, could I go to Dr. Alberto?
Good morning, Assembly. It's an honor and a privilege to be with you this morning. So my background is in medicine and in epidemiology here in the States, where I've been studying firefighters and cancer for over 10 years now. In the United States, we know that exposure to firefighting is carcinogenic to firefighting. I served recently in the International Association for Research on Cancer, where we produced a monograph number 132, which was evaluating the scientific literature, not only in the United States, but around the world, looking at the effects of exposure to the different toxicants that Professor Steek was speaking about and its relationship to the development of cancer. And it was classified as a group 1B, group 1 classification for cancer, meaning that the profession of firefighting increases the risk for cancer. So firefighters encounter many different types of toxins when on the fire scene, not only during real-life fire response, but also during practice exercises when they are, either doing prescribed burn, whether in wildland firefighting or in structural firefighting with building, and those toxins can certainly elevate their risk for cancer. And it's not all different types of cancers, but specific types of cancers, which I'm sure we'll talk about later this morning.
Thank you very much. And finally, can I come to you, Luke?
Yes, thanks very much, and thanks for the invite today. I think in terms of primary routes of exposure for firefighters, it's very similar to all sorts of hazardous chemicals. And the UK Fire and Rescue Service are well adverse in managing hazardous materials, all different types of materials. So I think this is the same as Professor Steck just mentioned in terms of ingestion, absorption, and inhalation. And if we create that link between fire effluent and hazardous material, we already have robust policies and guidance in place to deal with hazardous materials. So it's just transferring that across into the fire effluent sort of methodology as well.
Thank you very much. Coming back into the room now, Anna Steck, if I can come to you, is there anything unique or different about the kinds of exposure firefighters in London will experience as distinct from the rest of the UK?
Yes, absolutely, yes. So I think that the factors that would affect firefighters' exposure, it very much depends on the type of the fire and the fuel. So if we take, for example, wildland fire or any open fire like waste fire, they will have a different fuel or different products that are burning. So peat fires and grass fires are very common in the UK compared, for example, to Californian wildland fires. And then building will have obviously man-made products and many chemicals that are added into consumer products. Therefore, the concentration of chemicals will be slightly different. What we can see kind of coming from particularly observed in the US, that we're starting to have WUI fires, which is wildland urban interface fire, or we're starting to have from the wildland fire on the edge of the urban fires, and then buildings are implemented. Having said that, in terms of London compared to other brigades, we've got probably with the more rural fires, such as Scotland or Wales, firefighters will attend more wildland fires than in London. London is more, obviously, dwelling fires, so building structure. However, we can see also that firefighters starting attending wildland or grass or peat fires too. From our health monitoring that we completed last year, where we tested 1,000 firefighters from 8 brigades, we found that London definitely gets a lot of more frequency of fires, so they're attending a lot of more. And I can discuss later on the health symptoms and health outcomes as well in relation to London. If we take Grenfell, particularly on the high-rise building, a lot of factors contributed to that. However, we cannot clearly identify if Grenfell was one exposure that would lead to any deleterious health outcomes. In my mind, it can accelerate accumulative exposure depending on the activity and the role and exposure that firefighters suffered. Because the groups that we identify from the Grenfell were the firefighters who entered the building. And if they were wearing respiratory protection, obviously they were protected, but there were a group of firefighters who did not wear respiratory protection, and therefore their exposure were much greater. And then we've got a group of firefighters who were outside of the Grenfell Tower, waiting to be committed, and therefore the exposure was much lower because obviously it depended on the wind direction in terms of the smoke. So I hope I answer your question.
You really did, thank you. And PFAS was mentioned earlier for Forever Chemicals. Could I just ask you to elaborate on that?
Yes, so we've got man-made chemicals that are added to the product, and I would probably think that what we've got, sadly, in the UK is substitution of the chemicals. So a decade ago, we discussed gas-phase halogenated flame retardants, which are also man-made chemicals. And now we move to the PFAS, per and polyfluorinated alkyl. And PFAS are quite closely associated with the firefighting occupation because they can be found in firefighter gear and firefighting foams. I can develop information on the PFAS if the chair is wishing to that. Yes, so the most common perfluorinated chemicals or PFAS are PFAS, PFOA and PFOS, and just I would put abbreviation on that. And they were classified according to IARC, World Health Organization, as carcinogenic or possibly carcinogenic. In what we could see is that PFOA originally had 8 carbon chain, apologies for the chemistry, and when it was identified with carcinogenic and other health deleterious outcomes, it was replaced by C6. So kind of shortened the chain, also under the perfluorinated chemicals. So C8 is banned now in the UK since July 2025. It's replaced with C6, which also health outcomes are coming out to our knowledge. It's supposed to be phased and banned out in 2026. However, any other PFAS used in firefighting foams at the moment are under consultation of HSC till February 2026 to make decision if they're going to be phased out or banned.
And just to understand, did you say the C6, so it's gone C8, C6, and C6 is to be phased out by 2026?
Yes, that's the plan at the moment.
Thank you very much. Luke, if I can come to you online. Sorry, the 2 questions are if there's anything distinct about London and also anything you have to add about Forever Chemicals.
Yeah, I think, in my opinion, I think London is similar to the rest of the UK. However, what we need to bear in mind is the built environment in London is very different to most places in the UK. Therefore, they will have a higher volume of incidents and fire calls, I would suggest. However, as Professor Steck did mention, a lot of the studies, a number of studies, should we say, around contaminants have been around wildland fires, and London has a minimal risk, I would suggest, around wildland fires at this moment in time. That may change in the future. So that's just one thing to bear in mind. I would suggest that the volume of calls is the big thing with London Fire Brigade, rather than the built environment being different to anywhere else in the UK. In terms of PFAS, there's ongoing work within the UK around the removal of PFAS from firefighting foams, which is ongoing across the UK. And then we will assess any further regulations that come out maybe next year, or if they're delayed any time in the future, we'll consider those as they come out.
Thank you very much. And Alberto, just check online if you've got anything you wanted to add to this initial section.
No, I concur with both of my colleagues. I think when you think of large metropolitan cities, just like here in the United States, right, like large metropolitan cities, there are many, many high volume fires. So even small fires like a kitchen fire to a car fire, a dumpster fire to a full-fledged building on fire, all of those possess different ranges of risk. And so we think about the cumulative exposure that firefighters encounter, responding daily to these different types of fire that ultimately can increase their overall risk for the development of cancer. So yeah, I think unique in London is the volume and the varying types of fires. And in terms of PFAS, we share the same concern here in the States with the different point sources of fire exposure to first responders. I also worry about metals. So we see an increase in the use of electric vehicles and renewable energy sources with these different, micro mobility devices that we see. Those pose also new and evolving risk for cancer in the fire service.
Thank you. Assemblymember Hall.
Yeah, very briefly, because I know nothing about chemistry whatsoever. These new man-made chemicals, what country are they coming from that we're most concerned about? Because obviously if they're developed here, then they're under all sorts of scrutiny, one would hope. But if new chemicals are emerging from somewhere else and put into toys or whatever, that then if they combust, the firefighters are in danger. What areas or countries would you be most concerned about?
I think it's probably not from which country it comes, it's where it's manufactured. So generally what we can find is that, particularly in the UK, is that in order to meet, for example, building regulations in terms of the fire, and fire regulations are only testing, let's say, in time to ignition, and fire spread, but not toxicity. So therefore, chemicals are added to meet those two criteria, not looking at what might come out and how dangerous it might become to the health. So we can see, for example, that we worked last decade with the gas phase halogenated flame retardants, which moved now to perfluorinated chemicals, which we can see now replacement with some of the heavy metals, which Professor Caban-Martinez mentioned, that are introduced as a substitution to meet those building regulations, but they are posing a threat to human's life.
Okay, and is somebody particularly taking note of batteries that we seem to?
Yes, so that's a really classic example that the fire toxicity wasn't tested and the product was introduced to the market. And lithium-ion batteries, they will have definitely.
Sorry. Did you say it wasn't tested?
No, not for the fire toxicity and fire threat to human environment. No. So we're just only learning now what dangerous it can come up. It's similar with the solar panels and similar with many other products. But generally, we're only now learning how dangerous it will be from the acute perspective, so immediate danger, but also from the chronic perspective.
So this wonderful net zero could be really dangerous towards our poor firefighters. Absolutely outrageous, that is, especially given the amount of fires that are suddenly ignited with people incorrectly charging their bikes and whatever.
It's very disappointing seeing after the Grenfell Tower fire that fire toxicity is still not moved forward or introduced or revised.
Fine, thank you.
Thank you. Assemblymember Clark.
Thank you. I'm going to come to you first, Dr. Fear, and then I'll come to Professor Steck. How should we interpret and apply the IARC classification of firefighter occupational exposure as carcinogenic in the UK context?
Thank you. So I think sort of moving on to the link between being a firefighter and development of cancer, what is clear is that the evidence is quite mixed. And so there is strong evidence, and this is what was said in the IARC, that, for mesothelioma and bladder cancer, there is an increased risk, but the evidence for the other cancers is a lot more variable. And there are a number of different studies which have been done which show very differing results, which sort of gives a signal that it needs to be looked into a bit more. I think that mesothelioma is a well-recognised risk. It's associated with asbestos exposure, and it takes, on average, about 40 years to develop. So the exposures that we're counting now in firefighters who develop meso is from exposures maybe 40 years earlier. I think it is undoubtedly well recognised that firefighters are exposed to a lot of toxins and carcinogens, but whether that actually results in an increased risk of cancer in the UK, I think is less well defined at this point. Cancers are really difficult because there's a lot of interest in screening. But screening is complicated because when you're doing a screening program, you need to know what cancers you're screening for. You need to understand if there is a test to screen for that cancer. and doing tests on people, lots and lots of tests on people, is not risk-free. So if you do CTs on lots of people, you may discover things that then not go on to need further investigation, which turn out to be nothing, but have put increased stress, anxiety and resources on the NHS. So I think, that the obvious thing that people often say is we should just do a screening programme, but actually there's a lot of complexity which is associated with that would need to be thought through. And actually there's no good screening for mesothelioma, and there's very little screening programmes for bladder cancer that would work. So I think we just need to think about it and consider it, but there's not an easy answer. I think the other thing is that some of the studies have compared, whenever you're doing a study to look at risk of cancer in firefighters, you need to think who your comparator population is. And there are several studies which have been done which have compared firefighters to the general population where there's been an increased risk. But then you compare firefighters to other emergency service workers, so paramedics, for example, or the military. And then the risk comes right down, which sort of implies there are other factors, not just potentially firefighter exposure, that may have contributed to that risk of cancer. So we know that when you're thinking about cancer, important risk factors for which there's a very well recognised risk is shift work. Shift work leads to increased sleep problems, it's associated with mental health problems, associated with higher alcohol intake, poor diet, obesity. And we have good evidence that firefighters a proportion of firefighters have been smokers or current smokers, drink a lot of alcohol, binge drink, have poor mental health, etc. So whenever we're thinking about cancer prevention in firefighters, absolutely we need to think about their exposures, but we also need to take a more holistic role and think about other modifiable risk factors that we know have clear associations with development of cancer. So I think if we're thinking more broadly about what we should do to protect our firefighters from developing cancer, it should include all those other factors and sort of really think about encouraging these people. They're male, they often don't seek, they're often young, they don't seek healthcare, so they don't go and get their COVID vaccines, they don't go and get their flu vaccines, they don't seek help for health-related things because of their sort of general, the group of people they are. And that's general, it's not unique to firefighters, it's just young men don't see their GPs. So it's really about health promotion and sensible lifestyle modifications. I'll stop there, but can continue.
That's really interesting. I'd be interested in particularly about COVID vaccines and the uptake amongst general workforce and military and other blue light services. I've not come across a comment like that before, so I'd be interested to see that. Professor Steck.
If I can comment that. So we were approached in 2019 by Fire Brigades Union to evaluate firefighter occupational exposure in relation to cancers and diseases. And first of all, we actually look at the other countries. So, for example, United States recognized firefighter occupation as carcinogenic over 4 decades ago. And they introduced not only compensation, but also health monitoring, depending from the state to state. That has been followed by Australia. That has been followed by New Zealand. And then Poland introduced presumptive law in 2019. Then we had IARC recognition of firefighter occupation as carcinogenic. And that was followed by European Parliament in 2024, providing directive where they classified all firefighters are classified and their occupation classified as carcinogenic. UK is very different in terms that we've got Industrial Injury Advisory Committee providing recommendation on presumptive law for firefighters in relation to occupational exposures. And they providing that in order to classify any disease, it has to be double risk. So it has to be twice higher compared to general public. While if we look at the UK law, actually it doesn't specify that. It says that it has to be significantly higher compared to general public, and the proof between occupational exposure to the chemical and related to the cancer needs to have statistical significance, so it needs to be validated. Through our last 6 years, we actually found that firefighters have higher rates of cancer incidences and mortality in the UK. We've done this across not only survey, which firefighters obviously self-reported it, but also we've done our national health monitoring across 1,000 firefighters where we collected blood and urine and tested them for number of diseases and cancers or tumor markers. Generally, across all the studies, we found that from the self-reported survey, we found that 4% of our respondents out of 11,000 firefighters, they have been diagnosed with the cancers. And the top peak was between 35 to 39 years old, which is 3 times higher than population in the UK. The cancer incidences actually follow, some of the cancers follow worldwide findings in terms of the skin cancer, in terms of the digestive cancers, and also bladder and kidney, so neurological, and also neurological diseases and cardiovascular diseases. So they are not very, very different. But when we're trying to compare any data, I would really put a careful assessment because, as I said, other countries working on the presumptive law and health screening for firefighters for over 4 decades. So they've got not only procedures and documentation to protect firefighter and early diagnosis. And similar findings we found from our health monitoring of firefighters out of 1,000 on average, and this is only preliminary findings from our statistical data. So we collected samples from 1,000 firefighters and 300 general public. We found on average 10 to 15% of firefighters with the abnormal tumor markers. Obviously, it doesn't say that they have been diagnosed with cancer, but at least 1/4 of those firefighters responded by email to us saying and thanking for saving their life. Thank you.
So just a quick follow-up on that. So when we're talking about the incidences of cancer or sort of pre-cancer detection amongst firefighters, particularly young people, what I would consider young people, 35 to 39, is that higher than other blue light services and military? Because I thought what Dr. Fear was saying earlier was interesting about shift workers generally, and we're looking at different samples and different types of occupations. But is it higher amongst firefighters than other?
I would say there is no studies covering that topic. However, I would say that the cancers we're finding amongst firefighters, as in the World Health Organization report, is quite closely linked with the fire-derived chemicals, so soot precursors and polycyclic aromatic hydrocarbons, which are linked with the most commonly blood cancers.
So it just sounds like we need more research in this area. Is what this is. Yeah. This is what it sounds like it's coming down to. Okay, I'm going to go to Luke online. Luke, it's not going to surprise you the question I'm going to ask, but what work has the NFCC undertaken since the IARC classification of occupational exposure as a firefighter as carcinogenic to humans?
Yeah, thanks. I think it's important to put across that our actually work started before that was published. So our work started around about 2 years ago, this actual project, but the NFCC were aware of this risk way back in 2016 as well, when they first published their first position statement. I came to lead this group around about 2 years ago and created a number of different deliverables in terms of work packages. And I'll just run through each of those for you. So it's 9 altogether. So the first one is an evidence-based literature review. We have over 135 documents in our repository. A lot of those documents are included in the IARC report as it happens, which is rather handy because our IARC monograph 132 is kind of like the principal document we go to mainly for our work on contaminants, because that includes many, many other academic studies around the world. So it's all included in that one document. The NFCC also have a piece of work on PPE, personal protective equipment, a new type of fire kit and a new procurement contract for that, which is going to go out in the next 12 to 16 months. The third one is around risk assessments and safe systems of work. So we're creating a national suite of risk assessments for the management of contaminants. And to date, we have 11 risk assessments that are just going through, well, it's going to start to go through governance to be delivered. The next one is around appliances and equipment, commonly known as some people refer to as a clean cab policy. So that's keeping the internal cab of a fire appliance as clean as possible to keep that risk as low as reasonably practical. We're actually changing that terminology to a clean vehicle concept because we believe the risk is not just in fire appliances, it's also in flexi-duty officers' vehicles, fleet vehicles, BA technicians' vehicles and the like. There's also a work package on health surveillance and any recommendations that may come from that in line with the previous conversation we've just had. Training is the next one. So we're creating a national training package for the management of contaminants. And to date, we've got 7 different modules that we're identifying to to cover people from initial starter as an apprentice or a recruit firefighter, through to maintenance of competence and skills, a flexi officer or a level 2, 3 or 4 commander. Also covering people who may come onto fire stations or community hubs, so members of the public who may come into contact with contaminants, so it also covers that, a whole suite of people. The next one is around estates and property, so there's a strategy around how we manage our estates in line with contaminants. Respiratory protective equipment, and then also a piece on national guidance, so it's adding more national guidance in suite the national operational guidance documentation that we currently have, and adding our newfound information and studies into that and creating a new sort of guidance document for national guidance that services can use, adapt, adopt or reject as they see fit.
Yeah, okay, thank you for that. I'm going to come to Dr. Caban Martinez. Thank you, sir. Good morning. I realize it's early. Obviously, you said earlier that the USA is perhaps ahead of the UK in this area. I'm wondering, though, how has recent classification impacted policy and guidance in the US?
Yeah, it's very multi-pronged, both at, like the little p for small policy and big P for large policy at the state and the national level. So over the last 10 years that I've been working in this space, what I've noticed is at the local level within each fire department or brigade, the fire departments have been implementing local changes that they can do to reduce cancer risk. So Professor Steek was talking earlier about the different ways that you can come into contact with different carcinogenic chemicals, right? So you can have dermal absorption and then have those chemicals on your skin be absorbed from what you picked up at the fire scene or during a training exercise. Similarly, you can also do inhalation when you're off air. You can breathe in particulates that are in your area, and even ingestion, right, from secondary or tertiary transfer. In fact, I'll submit to the Assembly a really neat video that we did about 10 years ago using invisible dye. If we used banker's dye to simulate exposure of soot in a fire scene with a firefighter and allowed that soot to transfer as they return back into their apparatus, into the engine truck and back to the fire station, to show how there's primary, secondary, and tertiary transfer of carcinogen that you encounter in the fire station and back. And so that has changed a lot, that campaign, talking to firefighters about the carcinogens that we encounter when we're at fire scene has stimulated conversation around how we talk about cancer in the fire service. And so in the States, the data that has been generated has informed, for example, presumption law. And I'll give you a concrete example. I'm in the home state of Florida, and Florida has been able to develop a dedicated firefighter cancer registry. So in the States, every state has to record when somebody gets cancer, and that's a federally, nationally mandated. We're able to work with our state fire marshal to link the data from the cancer registry to the certification records for firefighters. And it's a very powerful and simple exercise, because what you can do is then give specific population estimates of what the cancers the firefighters are experiencing compared to the general population. And so if you see certain cancers that are more elevated in the firefighters, there must be something environmentally or occupationally related that's increasing that risk. So for example, in the state of Florida, which is consistent with some of the data from the IARC monograph on the world stage, we see that there's elevated skin cancer and prostate cancer, right? So some of these cancers, and thyroid cancer is another one. So to Professor Feary's point about, shift work can impact, thyroid dysfunction, because if you're not sleeping your regular cycles, it can throw your hormones off, and so sleep can also impact it. But some of these cancers are screenable. So for example, skin cancer is screenable, colorectal cancer is screenable, and so we try to target, through policy, how we can encourage firefighters that are at higher risk because of their occupational exposures to engage in these types of screening practices. And so in the registry data, when you have those statistics available comparing the firefighter workforce to the general population, we in the state of Florida, we've changed presumption laws, which assumes that if you develop these cancers that we see elevated based on the registry, that automatically it's presumed that they're because of the development of your profession as a firefighter. So in turn, the data that's generated from health monitoring and the cancer registry have impacted policy at the fire brigade level, so that there's SOPs specific to decontamination practices and screening practices. But then at the state level and at the national level, it's changed sort of presumption laws about assuming health coverage for and screening practices for the cancers that are at elevated risk for firefighters. And sorry for being long-winded. Probably haven't had enough coffee yet this morning.
It's really helpful, and it's really early. Thank you for that. Back to you, Chair.
No, that was great. Thank you, Doctor. Assembly Member Buck-Hari.
Thank you. So my question is to Luke. You've just been talking about the fire contaminants working group and the findings that you're getting from that. But I do want to ask additionally. It was in 1974 that the Health and Safety at Work Act was passed. Has there been a reason why there's been such a length of time between then and now before we've started to get to this point where we are working on the findings and the working groups project?
No, I think fire and rescue services across the UK have also had risk mitigation in place to deal with fire effluent in terms of breathing apparatus and other procedures they would have operationally. So there's always been a recognition of the risk. However, what I will say is I think with the emerging academic studies that have happened in the last few years, that has really come to the fore with new data for us to understand and interpret as a fire and rescue service. And that's why we're now putting more emphasis in this area.
Can you tell us a little bit more about the way you've been working with academics to collaborate on creating these inspection standards?
Yeah, so I think Professor Steck's report came out a few years ago, and all fire and rescue services read that and understood it. It was obviously worked in a collaboration with the Fire Brigade Union. That went out across the UK and was understood. And as a working group, we read that report and understood it and identified a large number of recommendations that were in the report for services to understand and adopt, adapt or reject. But it's not only with Anna's work that we've looked at a whole suite of other stakeholders. So personally, I've been involved with FEMA in the US and Stockholm Fire Brigade, and Sweden are arguably one of the world leaders in how they manage fire contaminants. We also worked with the HSE in the UK, and also I have regular meetings with NHCLG as well. So we're involved in a number of different stakeholders, and internally within the NSCC also, we've got our own ACER group as well. So they lead on a lot of academic research as well. So it's a multi-collaboration with many different stakeholders, I would suggest.
Thank you. Assembly Member Hall.
Thank you. And these are mainly to Professor Anna, if I can, please. What are the key findings from the UK Firefighter Contamination Survey, and what are the main health impacts identified from that survey?
Apologies for a little bit long answer, but the questionnaire has been designed covering contaminants exposure pathways. So we divided the questionnaire into 4 parts. One, looking at the exposure in relation to personal protective equipment and also workplace contamination. Second part was in relation to health symptoms and health outcomes, particularly on the cancer incidences. Third part was on the mental health. And the fourth was on a culture and badge of honor in relation to understanding on contaminants. From first part, which was on a personal protective equipment and workplace contamination, I think the key findings was that we identify statistical significance and relations of firefighters' exposures with the cancer incidences. So, for example, not separating dirty and clean personal protective equipment, also smell of the fire at the station, also a lack of personal decontamination. All of that was associated with the higher rates of the cancer incidences. I think the biggest finding that we found was that majority, around 90% of firefighters actually self-reported that they do not wear respiratory protection often or sometimes, and that's in association particularly with the big open fires. So that means that if there is a wildland fire or waste fire, firefighters will unlikely have respiratory protection wearing, and therefore they will be exposed to smoke much more. And also within the dwelling or building fires, we found that majority of the firefighters reported that they do not feel the need to wear respiratory protection when they're dumping over and knocking over. So when the main of the face of the fire is extinguished and it's still smoldering, firefighters do not feel the need to wear respiratory protection. And I think in relations of the policy kind of for enforcing firefighters on wearing respiratory protection, I would probably come back to Luke Gazzard on this one. The second finding on the health symptoms and health outcomes, we associated that there are specific health symptoms associated also with the fire effluents. So carbon monoxide, which is released in every single fire, it is associated with headaches within the longer term, and longer term it leads to the cardiovascular diseases. Similarly, with the soot precursors, benzene and PAHs, which are also generated in every single fire, they are linked and associated with the higher rates of developing and higher likelihood of developing cancers. Sadly, we had 11,000 responses from our survey, and 4% of those who responded to our questionnaire, they said that they have been diagnosed with the cancer. And the cancer actually, in very similar way, are confirming findings from the IARC. It was skin cancer, which is kind of dermal absorption, digestive cancer, which are associated and linked from our survey and findings with the eating with sooty hands, so kind of swallowing the soot, and prostate and testicular is also found in a kind of higher rate. We also found it on the mental health that anxiety and depression amongst UK firefighters is 4 and 3 times higher compared to general public. However, when we're looking at the mental health, there is more and more findings, particularly from the US, that particulate matter and PAHs are associated with the mental health disorder in a direct way. So therefore, looking from the exposure to contaminants and mental health, that might be in some way associated. And finally, culture and badge of honor and awareness. It's also very important, because if we're not changing culture amongst firefighters in relation to contaminants, particularly awareness, that also is associated with the likely of the lack of the contamination procedures or implementing procedures, and therefore developing higher risk of cancers.
So would you be making suggestions then that respiratory equipment is used more, especially when a fire is extinguished? I mean, is that what you're doing?
Yeah, I think I would suggest looking at revision of use of the respiratory protection, particularly when during the open fires, as well as when the main fire phase is extinguished. So in relation to, for example, in a dwelling fires, it's knocking over, dumping over, and so on.
Okay. Did you want to come in, Dr. Joanna?
Thanks. I think Hannah's study highlighted a really important point about education and behaviour, and maybe Luke will come back to that in a minute. The only thing I would sort of add is that you know, when you're looking at studies, you have to be so careful about self-reported outcomes. Because there is a sort of phenomenon that if you ask a group of people, a population of people, to take part in a survey about practices at work and development of disease, you're much more likely to reply if you've got a cancer than if somebody who thinks, no, I'm completely fine. And so all your proportions and percentages that you report have to be in the context of understanding the denominator and the size of your population at risk. So, you know, any studies need to be interpreted with that in that basis. And it's also really important that you adjust for confounders. So you adjust for things like smoking, obesity, use of sunscreen, holidays abroad, or whatever it is, depending on which cancer you're looking at. So there's just a caveat there about looking at self-reported data. And of course, if you're not checking against medical records, people can over-report a skin tag that they were told might be cancerous but turned out not to be. So that sort of thing.
No, I understand that. Luke Gazzard, would you like to come in? Sorry, you're all over the place in this place.
Yeah, thanks. Yeah, if I could just come in on use of breathing apparatus, actually, I think is a really important point that Anna picked up. You know, through the NFCC national guidance, we have robust policy around when firefighters should wear breathing apparatus. So we feel that that's quite well embedded across the UK. And I'll give you a comparison in terms of other countries around the world in terms of how they use breathing apparatus. I feel our breathing apparatus use is far much more robust than anywhere else in the world generally. I think we have strict protocols around entry control points and when people go into a risk area with smoke in it and when they should be wearing breathing apparatus, which is enforced on a daily basis across the UK. In other countries, as an example, quite often they get given the choice of when they want to don their breathing apparatus mask. So I believe our control measures are absolutely much more robust in other places around the world. Just going on to the culture piece, I think that's really, really important because this is around education, and although we've been much more aware of the heightened risk for a number of years now, the services are doing their own work on learning, education for their teams and trying to change that culture. So the badge of honour does seem to be slipping away and going across the UK, which is really, really important. So that highlights to us that services are educating their firefighters on the dangers and the risks from contaminants. That's really, really important. What we're finding in some places across the UK are that the risk is there with firefighters. In fact, is there to the point that sometimes they feel they can only wear once if they enter, as an example, a domestic dwelling fire. You know, they come out and they feel like they can only wear once because they're covered in fire effluent. That's not the case. So it's gone back the other way to a certain degree. So there's another bit of education we need to do now to manage that risk and make them aware of all the risks and when they shouldn't decontaminate.
Talking of, well, while we're on that, it's a question I've often wondered and never asked. How are these uniforms cleaned?
So there's a number of different options, different service contracts within the UK. I can only speak for Avon Fire and Rescue on this particular matter. We have a service contract with a provider. They provide our PPE and a laundry service to us. So after an incident, a firefighter would get back to station, or actually on the incident ground, make a determination of how clean or how dirty their PPE is. And if they feel sufficiently dirty, it needs cleaning, they will then bag it up on the incident ground, transport it back to station, and then in Avon, it would then go off to a launderer who collects once a week for us at this moment in time. What we do now know is that this is putting a massive pressure on services, capital or revenue budgets, because the cleaning bills and the PPE use through good education is increasing, and that's putting a pressure on revenue costs.
And are they cleaned with detergent and water, or are they dry cleaned?
I think it's a warm water solution, but I'm not a specialist in that area, sorry.
No, it's something I've just wondered, knowing that, you know, whether chemicals are used to clean them, whether that would have a knock-on effect on chemicals. It's one of those ridiculous questions, I think, in the middle of the night, and there's nobody to ask. But there we go.
I think just on that point, it's quite relevant, actually. The NFCC PPE group, who are looking at the new procurement contract and the new standard for PPE, firefighting kit, are doing a piece of work on wash temperatures as well, because the temperature of the wash does impact on how much dirt is removed from that when it's being washed.
And has any work been done on how many times they can be washed before the fabric actually deteriorates, so it's not as effective?
Yes,
because I mean everything is around their uniform to make sure that they're kept safe. So I just wonder, you know, how many times can something be washed before it's marked up?
Absolutely. That piece of work is being done by that PPE working group. I don't have the data to hand because it's a progressing piece of work, but that is going to be included in the new specification.
Good, because I would imagine that is really quite important. I think you wanted to come back, Professor Anna.
Yeah, if I can, I'll just come back with the comment that Dr. Fury did. In terms of the self-reported, we were aware that those reports and those answers of the firefighters who have been diagnosed are self-reported, which kind of followed with actual health monitoring. So we collected 1,000. We collected blood and urine samples from 1,000 firefighters and 300 general public, and we tested that in relation to the different clinical markers, but also in terms of the persistent organic pollutants or forever chemicals identified in firefighters. We also additionally we created something what we called Firefighters Cancer and Disease Registry, where firefighters are providing all information. I have to say that it's kind of, the questionnaire was kind of worked together with Professor Kevin Martinez, that kind of he developed in his state. And we actually got access to medical reports and the concerns from firefighters who reported cancer incidences to access that data. So far, our cancer registry's got 8,000 firefighters registered. Over 1,000, we've got firefighters registered with cancers, and around 900 firefighters registered with diseases other than cancers. And that registry only exists for the last 3 years.
Okay, when you did your report, did you do a comparator group, though?
Yes, we did. So within the questionnaire, self-reported questionnaire, the original questionnaire that was in 2020, that was between firefighters only. But when we did health monitoring on 1,000 firefighters, we did general public, 300, and firefighters, which was around 1,000. Okay. So we've got control group, and we're actually looking at the co-funders. And then to pick up your question about cleaning of personal protective equipment, and I think Dr. Caben Martinez wants to come back as well on that one. We know that there is cross-contamination when the firefighters are putting PPE into the washing machine. So as soon as it's contaminated and it's going to be professional cleaning, there is enough studies showing that actually cross-contamination of contaminants is very common. Some of the countries like Belgium and also some of the states in US propose now carbon dioxide methodology, which is kind of non-invasive and gas permeability of removal of contaminants. But there are still very limited studies to show the effectiveness of these methods.
Interesting, thank you. Dr. Alberto Caban Martinez.
Yes, good morning. So I just wanted to provide a quick comment on the cleaning of the gear. I think having clean gear is essential. It's basic hygiene to make sure that there's no transfer of carcinogens that are encountered on the fire scene back to the fire truck or back to the station. Dr. Kenny Fenn published a paper. He's from the National Institutes for Occupational Safety and Health here in the United States, showing that basic soap and water is able to eliminate 84% of these chemicals, polycyclic aromatic hydrocarbons, that are products of combustion that firefighters encounter. And I think this is really important because there's not going to be a silver bullet that cleans, firefighter gear from all different types of chemicals that they encounter, right? Depending on the fire, whether it's an electrical fire, a stovetop fire, or a full-blazed structural fire. But cleaning of the gear is really essential to have that. Here in the States, some fire departments that have the financial resources issue their firefighters 2 sets of gear so that they're able to have, the primary one that they're using, and should they do fire response, they have a second backup while they send their gear out for professional laundering, so that they clean it and have a set of gear. You wouldn't want your GP to come visit you soiled in blood when they come to see you in the consultation room. We wouldn't want our firefighters to have decontaminated or contaminated gear as they're going from fire to contaminate their co-workers and the other people that they're responding to. And I also wanted to share one comment also on education. So in the States, firefighters is a vocational training. You go for a couple of weeks to fire college and you train as a firefighter. In the States, we actually changed legislation to mandate 4 hours of firefighter education on cancer prevention and control. So all firefighters, as part of their curriculum to become a firefighter, have to complete this 4-hour educational curriculum in order to create awareness of how they can mitigate exposures to carcinogens and do health monitoring and screening that is appropriate for their profile. It's harder to do it once the firefighter is back at the brigade or at the company, because usually the fire brigade controls the education that they do annually for it. But in general, the legislature worked with us to be able to require that all new firefighters have to complete a certain minimum number of hours in cancer control and prevention education.
Thank you. And no, you certainly wouldn't want a doctor approaching you in that manner. I'll give you that. But if it's 84%, then there's 16% that hasn't been removed. And if that's a toxin that can't be removed by whatever you're removing it with, warm water or soapy water, if that 16% then builds up, does that not cause a problem? Alberto.
Yes, happy to respond. So I think if you speak to any injury prevention professional, they'll tell you you can never reduce risk down to zero, right? It's just impossible. There's going to be risk inherently in everything they do, especially with our firefighters. So there will always be chemicals that are in their environment. And I think any approach that minimizes the different types of toxins, whether they are metals, microplastics, PAHs, is there. In this particular one study that Dr. Fent did, yes, he said that there was an efficacy of removal of around 60%. I will defer the technical aspects to my colleague, Professor Steek, who's much more smarter than I am in the world of chemistry and can explain sort of them. But, as you launder clothes over and over, you remove different types of chemicals. In the States, the gear is normally, and from industry of the manufacturers that produce gear, it has a lifetime of around 10 years. Gear usually is taken out of service once you issue it to a firefighter, because it has to be cut out for their size, their anthropometric measurements, whether you're a male or a female firefighter, and you may tailor it to you. That gear is supposed to last you around 10 years. Sometimes they retire the gear earlier if it's gear that has, you're in a very busy station and your gear has withered away faster. And sometimes they try to keep it to 10 years. But, usually there's, chemicals on it. You'll never be able to get it down to 0%.
Okay, thank you. I think I've asked enough questions about washing. Who knew I'd ever be asking questions about washing? And everything else has been answered.
Thank you very much. Assembly Member Bakari.
Thank you. My question's to Dr. Furian. You've been asked to do a study, to conduct a Grenfell firefighter study. Can you tell us about the key learnings so far that leading on this study, and what future data analysis will be undertaken from it in terms of follow-up studies to identify long-term health issues?
Yeah, thank you. So this study, we weren't asked to do the study. This was a kind of academic initiation in conjunction with London Fire Brigade. Just to clarify that, and by way of background, so I'm a respiratory NHS consultant, and I work in the Occupational Lung Disease Clinic, and I see most of the firefighters in London Fire Brigade who have any problems with their respiratory health or with their lung function, which is carried out on a regular basis at their annual assessments. And so they're done in occupational health, and then if there's any problems, they refer in to us. So we've got a long-standing relationship with occupational health. And I think because of interest in the issue of firefighters' health, the Grenfell firefighter study sort of arose. And it was set up to look at the medium and long-term health effects of being a firefighter. It was independently reviewed, and it's funded by the Colt Foundation, who are an independent charity who fund research into occupational medicine and occupational health populations. And we recruited around about 650, 700 firefighters from around London, and we had their lifetime occupational histories from LFB, from the records. And we have categorised those firefighters into two groups. The first thing is based on the tertiles of fires attended. So we counted all the fires that everybody had attended, and then we looked at the low, the medium and the high numbers of highest group of fires, so that we could do a dose response, so compare the lowest exposed to the highest exposed. And we also looked at their role at Grenfell. So the fire, as Anna's already spoken about, included a group of people who were there in the first 23 hours of the fire who had the highest exposure. And in amongst that were some individuals who were in the tower without breathing apparatus. We looked at people who attended from day 2 to day 13, the so-called recovery period, where they were also exposed to sort of Grenfell dust and products of combustion, and then a group of non-attendees who were employed by London Fire Brigade at the time but were not there either because they were on annual leave or they were part of a service that didn't call up. To date, the only study that we have published is on cancer biomarkers. I'll come back to that in a second. Our main analysis are on respiratory function over time to look at how lung function changes over time with firefighter exposure. We're preparing that paper at the moment, so I can't really share those data. We're also looking at cardiovascular risk factors, and we are looking at cancer. And so the cancer paper that we've published to date is very much an exploratory study. It was on a subgroup of people because this sort of study is very expensive and we didn't have the funding to do the whole population. And we looked at a panel. We were looking at cell-free DNA, which is a fragment of DNA which circulates in the blood. And we were looking for changes in the amount and the type, the changes in the DNA that have previously been associated with cancer in 50 different cancers, in 50 different areas of the gene. And what we found was that, and we were doing this analysis with an assumption that firefighters are at increased risk of cancer, to try and understand if this could be used as a test that could be used for screening or would give us any understanding about mechanisms by which cancer would be developed. And what we found is, and I'll just have to look at my numbers just to double check. We did the study on around about 250 people, and we found only 11 of these pathogenic variants, and they were in 11 different people, and they were all for different kinds of cancers, and they were all minor, or they were almost all minor changes rather than sort of the more concerning changes. Now, these are subtle changes. It's way, way back in cancer development, so it doesn't mean that these 11 firefighters are going to go on to get cancer. It just means that they've got these subtle changes. I think what was important for us was that the numbers were low, so overall, we didn't find many of these markers. And when we looked at our categories of exposure, there were no significant differences statistically between their role at Grenfell, so the fire versus recovery versus non-attendees, and there was no difference based on tertile of fire. So the people in the lowest exposure had around about 450 fires they'd attended versus 1,500 in the highest group. And there was the differences between the groups in the number of people with pathogenic variants didn't really significantly vary. So this is not a conclusive study in terms of risk of risk of cancer in this group. But what it tells us is that the numbers were reassuringly low. This is a well-recognised panel associated with lots of cancers. Numbers were very low, didn't vary by smoke exposure, but there are many other studies that need to be done to look a bit more at it.
I'd like to know a little bit about what you think those next studies need to do. Should there be a focus on consistent exposure to fires? Should there be more of a focus on lifestyle, that you were talking about, things like smoking, obesity? What would be your proposal, what we need to do next?
I mean, I think we need, I think it would be very useful to have a really robust nationwide study to look at the risk of cancer in the UK firefighter population, with adjustment for confounders appropriately, an assessment of exposure. I also think we could work on the basis that there are lots of if we work on the assumption that firefighters are at slightly increased risk of cancer, for example, then we could look at the whole population, the whole sort of holistic risk factors, and look at how we should be modifying it. So there's obviously work to do around education, based on Professor Steck's study and other work. Education, changing culture, I suspect, around wearing of the BA and using it properly. And I think, modifiable risk factors, exercise, reduction in obesity, alcohol, sleep, mental health support, if we're finding prostate cancer in firefighters, then they should be attending their screening programme. There's a UK screening programme to have your PSA checked. So I think that we can do more epidemiological studies, but also there are things that we know we can modify that firefighters have a high prevalence of, so that those should be addressed.
If I can just add it, in relation to evaluation of exposure, we also need to be very careful that we're not counting number of fires as exposure, because that's wrongly assuming that all firefighters doing the same activity for the same time, they're doing with the respiratory protection they're wearing or not in the same way. So when we evaluate exposure, that needs to be really looked at the smoke quantity, type of the fuel that it's burning, activity time, and also, respiratory protection if it's one or not. The counting of number of fires giving wrong assumption that that's exposure. Also to add it in terms of looking for the future study, if I can add, we actually working together at the moment with the Scottish Government and Scottish Fire Rescue Service through the CivTech Challenge, where we're developing a mobile app that will record firefighters' exposure to contaminants and also their activities, time, duration, and other co-founders. And that would, in that way, it will not only allow firefighters but also management to assess and mitigate their exposure, but also change their culture.
I need to go to Alberto on the screen now. So my question to you is, how many individuals have enrolled in the Firefighter Cancer Initiative that you've been conducting, and what has been the impact of that initiative thus far?
Yeah, so over the last 10 years, we've estimated that our collaborations have been over 80,000 firefighters at the national level in the United States. And this is across many different types of Firefighter Cancer Initiative activities. We organize the Sylvester Firefighter Cancer Initiative across 6 pillars. So one of the pillars is our cancer epidemiology and cancer registry, which allows us to track the specific types of cancers that arise, and that's a natural participation just of the development of cancer. But then we have individual studies, as Professor Steek and Dr. Ferry have been talking about, where we engage individual fire brigades to participate in various studies, both not on just cancer screening and self-report, but also organizational culture and climate around cancer screening and decontamination practices. We also provide mobile services. So one of the things that we found very useful in the States here is that we bring the clinic to them at the fire station. So we have jitney vehicles that have been retrofitted as examination rooms. And when the firefighter is on shift, we provide their annual physical exam there with our healthcare team in order to do that. And that has increased participation within various cancer screening practices within the fire service. To Professor Steek's point, we've also developed a personal exposure reporter app, which is a mobile app that's downloaded on the firefighters' smart devices that allows them to personally track and develop a diary of their individual exposures and symptoms that they have. So participation provides positive engagement in their tracking of their own exposures and cancer screening practices. And then also biomonitoring. So we have several firefighters that are longitudinally involved in cohorts that we are collecting blood, urine, saliva samples, not only to create a biorepository for long-term exposure, but also to be able to look at acute exposures to different fires. And so across the years and through multiple of these different studies, we've had lots of participation in it. You find that it creates awareness and engagement of the fire brigade. Firefighters tend to be very competitive, at least here in the United States. And if one fire brigade is participating in a study, then the other ones want to, increase their numbers and their participation and enrollment.
Yeah, I mean, I'm really impressed with the amount, that 30,000. That's incredible. So you're still conducting this survey, am I right in thinking that? And how long are you going to be conducting this, and when will you be able to produce the final findings of that?
Yeah, so the longest serving cohort right now is called the Firefighter Annual Cancer Survey. It's a very basic survey that you give to the brigade, and they, annually answer the survey to have some insight into what their practices are. That has been going on now for 10 years. The intent is to run it through 30 years, so we have the lifetime course as long as possible. So we have some firefighters that have been participating since its original inception. There has been some attrition where some of them have fallen out over the years, and then new ones that have joined. The cohort, it collects not only self-report, but again, these biological samples that I mentioned earlier around urine, saliva, toenail samples, so that we can look at many of the chemicals that they're exposed to. Over the years, we have published several studies using the cohort, so that way we are learning different aspects about lifestyle, for example, drinking, smoking, obesity, that are inherent to cancer risk. And then other studies that have been looking at sort of cancer screening practices and organizational practices. For example, when we launched the campaign for decontamination, we gave every fire truck a bucket to make sure that they had soap and water and the brushes to clean themselves where they're on site, we ask in the annual cancer survey, have you been using it? How have you implemented it? So that we can track progress of utilization of the interventions that have been done within the individual fire brigade.
Thank you. I'm just going to end with one quick question to Luke. It sounds like a massive feat to be able to do something similar. Is that something that you've thought about maybe doing here? But is it a challenge? Is it really something that is going to be difficult to do, or not? What do you think?
That will be a challenge to do in the UK. There's no reason why it can't happen. But what I would suggest is that it's been in our conversations as a project group. We're waiting to see some of the studies from the US. I'm also in contact on a frequent basis with Kenny Fent, who Alberto mentioned earlier, who's leading on that piece of work. So that's a useful sort of collaboration we have. What I will suggest is that if this is to happen, it needs to be a collaboration of people, not just done in isolation between the NFCC. It needs to be with the rep bodies and other external stakeholders as well. So it's a joined up piece of work. What I will just say, well, caveat to all of this is, it's okay to have that data of one is how do we use it, and two, how relevant is it in terms of we can all acknowledge there is a slight increase in the risk to firefighters in terms of cancer. We all understand that and accept it. However, what we don't understand at this moment in time is, did that cancer come from the active role of firefighting, or did it come from another route, like somebody's secondary occupation or their previous occupation before they joined the fire service, or is it genetic? So I think we also need to try to understand that at some point as well. That's going to be a key point moving forward.
Thank you. Assemblymember Cooper.
So Luke, do you believe that we need to have a national firefighter registry or a database along the lines that Professor Dr. Alberto Juan Martinez has just been discussing? Do we need something like that, and do we need to have a sort of longitudinal approach to this so that it's something that we're looking at really over time?
A lot of the leading countries in the world have that type of study in place, and it makes sense for us to have something in the UK to monitor people in service and also retired personnel, I would suggest.
Thank you. Joanna, do you think that would be helpful? Because when you were discussing your approach around Grenfell, and I heard you in there saying there were some restrictions due to finance, but having something that's a sort of very long-term, ongoing approach like this would obviously give you some of that sort of background and wider and longer data that might be helpful to having those specific, more detailed studies. Can you microphone?
Thank you. I think just coming back to what Luke just said, we have to think about what the purpose is, because longitudinal registries are really expensive. And if we had unlimited resources, that would be fine, but they have to be maintained. You have to chase for data entry, you get people dropping off, etc. And there's a difference between what a registry would allow us to do is to track people, but it's not going to be used as a screen. So you're not detecting people any earlier. All you're doing is counting people. And if you count people, it may take quite a long time, like tens of years, to see any obvious trend. And actually, if what we're interested in is trying to reduce cancer incidence in firefighters, then I think we don't need to wait for a registry, and probably resources would be better spent somewhere else. So there's separate things, isn't there? There's cancer prevention, there's screening, which we haven't really touched on, but there's also the registry to record people. And I mean, data sets like that are invaluable, but they're also very expensive and they take a long time to come to fruition and become useful. So you know, without any resource limitation, absolutely fine, but I'd be cautious about setting something up otherwise.
Yeah, we're going to come on to some issues around PPE and decontamination and culture and behaviour. I mean, I've been noting from what you've all been saying that wearing your PPE, wearing your breathing apparatus, taking your kit off and decontaminating it, washing yourself thoroughly, decontaminating yourself all seem to be quite important given the routes of contaminants to get into or onto the firefighter's body. But it also seems to me that if you're going to look at all of those, which I think are very valid and probably we'll come on to in more detail in a minute, you've also been talking about the wider context. And in fact, actually, I think it was Anna who set this out right at the very beginning, that other factors like obesity, smoking, mental health issues, drinking are all adverse issues as well. I just wondered, when we're looking, and this is maybe also one to ask Dr. Chaban Martinez as well, when we're looking at those sort of specific individual biomarkers, if you like, or people's sort of way of living, are we also looking at where they're living? Because one of the things that we've done a lot of work on in London was discovering that diesel is not very good for health. We've talked about particulate matter. Diesel obviously generates a lot of that, so the ultra-low emission zone has been aimed to reduce the amount of particulate matter in the London urban area. And actually, if you look at some of the big studies, you would have thought as fires decreased, as smoking decreased, the number of fires attended decreased, you would have thought that lung health would have improved, but it didn't. And if you then look at the amount of diesel cars on the road, they kind of go up just as fires go down. So you could argue that source of particulate matter. So are we looking at where people live as well as all these other more individual factors?
Yeah, so in any epidemiological study, you would ideally be using the postcode of someone where they live to account for this. And I think one of the things that I was going to mention is that in the IAC report, which Professor Steck mentioned, they do make the point that a lot of these forever chemicals are common environmental contaminants. So even though firefighters are exposed to much higher levels, things like PFAS, I think, is in the London water. I think we're all exposed to it, and there are lots of these contaminants which are around, and so having postcode data, epidemiological studies, you use crude approximations to get the data you need, but postcode's really important. And a lot of firefighters will commute in; they will live elsewhere, and they will commute in, and depending on how they commute and how often they commute and where they live, their exposure to things like diesel will vary greatly. So it's a really important point.
Right. I could see that Anna was indicating that she wanted to come back in,
Yeah, I think just to come back on a few points, we are already running registry in the UK since 2020, and it's actually almost copy of the one that Professor Chaban Martinez mentioned, because he actually helped us to develop one. That's funded by Fire Brigades Union, so we're collecting actually all the information in relations of firefighters' activities, exposures, their lifestyle, also exposure to contaminants. That would not only provide information to firefighters, exactly as Professor Chaban Martinez mentioned, track their own exposures, but also identify any patterns that need to be addressed, not only by the fire rescue services, but also in terms of the changing culture and increasing awareness. And that actually moved now a step forward by the Scottish Fire Rescue Service that wants to implemented that in the Scottish Fire Rescue Service as the mobile app, which also is developed quite well and run in the US for the last probably decade or longer. In terms of the registry, I think it needs to be public and to provide the data, so it's not only kind of one group of academics or two groups of academics that are spending years on the research can publish publication, but it's publicly available data that anyone can analyze it and access, because at the moment we're really struggling with any access data in the UK. And then it also kind of prevents and protects firefighters a bit better. In relations to decreasing number of fires and decreasing also having healthier home indoor, yes, that's true. However, we have to take into account that we've got replacement of natural products with the plastics materials, which increasing concentrations of the chemicals and toxic chemicals. And the third point I would like to kind of kindly mention is mentioning obesity. I would like to point out that many chemicals that firefighters are exposed from the fire-derived chemicals are associated also with obesity. So we have to be careful when we're talking about obesity. In terms of the smoking, we know that the firefighter sector is the one that actually do not smoke. Very few firefighters smoke in the firefighter sector. It's actually much healthier population than general population.
Thank you. That's really, really helpful. Luke, I wondered if I could come over to you, whether you want to comment on any of that that we were just touching on about whether or not we should have the same kind of registry and doing that monitoring of firefighters. And then I just wonder what your thoughts are about the best approach to ensuring firefighters are proactive in their coming forward for health checks. And I noticed that Dr. Jabal Martinez talked about bringing the screening to the fire station. Is that something that is particularly helpful to make sure that the firefighters actually get their screening and take a positive approach to their health?
Yeah, absolutely. I think cancer screening, we talk around bladder cancer. I think the efficacy of the screening in the UK gives a lot of false positives and false negatives at this moment in time. So I think that is a process that we have in place in the UK already. So firefighters at any age, the general population can go, as long as they hit certain criteria, go and ask for bladder cancer screening. So that's already there. I think whether we bring it to the station or we bring it to another venue, doesn't really matter. What we absolutely need is a process in place to ensure that firefighters are being screened for the relevant cancers that are identified through academic studies like the IARC report. And I think that's really, really important to bring it back to that. At the moment, we've got processes in place in the UK for mesothelioma and bladder cancer, and those are the two that are linked in the IARC report. So as a working group, we're looking at those in our health surveillance work package initially, because those are the two that are identified, and then we will go on to the other ones that are identified in that document in phase 2 of our work.
Thank you. Dr. Jabal Martinez, any lessons from the States on how to get firefighters to be proactive around their health checks?
Yeah, that's a great question because organizational culture and climate is what sort of lends itself to it. I mentioned earlier about sort of the natural nature of firefighters to be competitive with each other. I have found over the years that encouraging participation and awareness as a group effort is really important. We've done a series of campaigns on. We talked about badges. A clean gear is the new badge of honor, right? And sort of rewriting understanding of how being clean is more important than being dirty. And we've done that through various short videos, like I was mentioning earlier, and I'm happy to share with the assembly the video we did that's like 4 minutes, showing how dye is transferred, right? I think changes to organizational culture are really important. Dr. Fear, I think, highlighted, how some firefighters, particularly younger ones, feel that they're impervious, their health is perfect, therefore they don't have a need to engage the NHS for regular health screenings, but showing them early on that, the long-term exposure, as this is your career and that you want to spend the next, 30 years doing this for your life, how we can reduce those community exposures, have been successful in getting those engagements. I think doing report back letters, so academicians and scientists were often guilty of not often reporting back the results individually to the participants of those studies so that they see themselves in that study, right? Like, oh, this was our station, this was our brigade that was participating. And I think these small little sort of engagement points and moments really increase firefighters there. I do want to just give a brief comment on the registry. I think it is very important for any brigade or geographic municipality to have some sort of way of counting the cancers that are arising in that population, not only to contrast it against the general population so that we know whether this is arising from environmental or occupational causes, but to know whether the interventions that you're offering are effective. If we go forward 5 years from now and we implement, say, decontamination practices or second sets of gear for firefighters or mandating educational sessions, how do we know that they're effective at reducing those values and having a registry there? I'm actually jealous that, in the UK that there's a National Health Service and there's a universal electronic health records. We don't have that privilege here in the States. Everything is piecemealed. And so we spend an enormous amount of energy and funds trying to put everyone's medical records together. I think there are some very simple, low-weight costs, outside looking in that perhaps we can do to sort of make sure that we're counting the cases through a registry and biomonitoring the firefighters in a way that's informative, not only, to the cancer experience of the full workforce, but also how these interventions that we're discussing could ultimately have an impact long-term on protecting our firefighters from cancer.
Well, that's really interesting, and also nice to hear that the National Health Service has that value, and that's seen internationally. I was actually yesterday in Putney, where Clement Attlee was brought up, who was the British Prime Minister at the time when the National Health Service was brought in the late 1940s, which was quite moving. His grandson was there and was talking about the work that he'd done. And, of course, we moved to a situation where you don't have to pay at the point of need, which does mean that people are probably more likely to come forward here, as well as that sort of big data impact that we get. But I can see that Joanna wants to come back in and say something else about how do we persuade people who feel invincible, which is possibly everyone in their 20s, not just firefighters, to have health screening and health checks, or anything else that you wants to come back on in this area.
Thank you. Just a couple of points. So in the Grenfell firefighter study, 8% of the 685 people were current smokers, and 25% were ex-smokers. So around a third had either been smokers or current smokers. And the BMI ranged from 20 to 49. Ooh. And the average was 27. And I think we have this perception that firefighters are very muscly and therefore BMI isn't a good measure. But there is data from another study which used sort of biometric measures of fat and correlated with BMI and showed that actually BMI may even underestimate people's body percentage fat. So I think you see a lot of lean firefighters, but there are others at the other end of the spectrum. Just in terms of screening, we touched on screening just briefly. That there isn't the two cancers that we have the strongest evidence for are mesothelioma and bladder cancer, and there isn't any good screening test for those cancers. So that we have no valid, safe, reliable test by which we can check for bladder cancer. Bladder cancer, you'd need to have an invasive cystoscopy, which means a general or local anaesthetic. It's pretty invasive. It's a day case procedure. So we can't screen firefighters in that way in the UK. Things like prostate cancer is much easier. You do a PSA test. And there are a few kinds of cancers where there are tumour markers, but there's literally about 4 that I can think of, sort of pancreatic cancer and some of the bowel cancers. You can do a stool sample for bowel cancer, so you can do certain things there. But just to clarify, the ones we're most interested in, there is no good screening test that we use in the NHS. But the other thing I just wanted to sort of mention, and Luke, you may know more about this than I do, but firefighters have to attend routine periodic medicals every year or every few years because of their roles. So they have occupational health services embedded within the fire services who see them every year, who do things like their respiratory functions, they spirometry tests, they ask them about symptoms, they ask them I think about smoking, they'll do a blood pressure check, and so they have a sort of health screening to make sure, because they're exposed to things like asbestos, and to check that they're fit for work. And Luke, you may want to elaborate, but firefighters already have that. So if we're going back to how we could improve education and encourage them to take part, I think using the occupational health services to try and do health promotion would be a really easy way in and an important factor, because they have to attend these things to do their job, their medicals.
OK, well, that's a really easy route, isn't it, to persuade people if they've already got something there. Anna, you wanted to come back in.
Yeah, I think I don't think we need to really get extra measures to get firefighters for testing. So we were testing 1,000 firefighters, but we had literally 9,000 firefighters applying for the testing. And currently we've got also 4 brigades asking us to come back to carry on again testing for firefighters. I think that the approach we've taken is that we travel with 16 team to the stations to carry out the testing on firefighters. But we really didn't struggle to encourage. We didn't have to encourage firefighters to participate in our testing.
OK, so they were keen to come for. Sorry, you wanted to come back in, Joanna?
Yeah, so I think probably the difference is that we're talking about, I think you were talking about doing screening for cancer, whereas this is health promotion, so talking to people about attending for vaccines, good sleep hygiene, getting support for mental health, etc. And so it may be easier to persuade people to attend for one kind of testing or screening than another kind of testing.
Okay, well, we're going to come on to that whole sort of area about decontamination and then culture and behaviour very shortly. But thank you very much, all of you, for those answers. That was really helpful. Thank you, Chair.
Thank you, Assemblymember Cooper. I saw Luke, you signalled. I don't know if you still want to come in.
Yeah, I just wanted to pick up on Alberto's point around the NHS and how things are in the UK as opposed to the US. The NHS is a fantastic institution, but undoubtedly. I was lucky enough to be in Washington, DC last autumn, and I went to the local fire service and we went to their medical centre and looked at their screening and health programmes for the whole health and wellbeing for their firefighters. And that is funded on a very, very local basis. And that's not transferable to the UK at this moment in time in terms of how it's funded, because services in the UK will struggle to put that amount of capital investment into health screening and health monitoring and wellbeing at this moment in time, the way we're currently funded. So although Alberto may be very appreciative of the UK, I really like the US model, but it's very, very different and it's not really transferable into the UK at this moment in time.
Thank you very much. Assemblymember Tyrrell.
Thank you, Chair. So this first question is the whole panel, so I'll start with Joanne, work across, and we'll go online secondly. So could the panel say, what do you think the biggest challenge is in stopping fire and rescue services from consistently providing firefighters with properly fitting and effective PPE?
Thank you. I can't comment on that. I don't know how the chain of provision of PPE it works, so I'll
I think harmonisation, obviously, as it was mentioned earlier, fire brigades like challenging themselves and they often work in a competition. But also, I would say probably majority of the affecting PPE would be funding.
Oh, sorry, I think I forgot to put the mic. If we go to Luke first, online.
Yeah, I think it's to a degree it's still an emerging risk, so we need to identify what emerging risk is in terms of how it affects us in our PPE and how we use it, how we clean it. Currently, the NFCC are doing that piece of work on the new PPE contract, so that will come to the fore in the very near future. But as Anna did mention, there are real difficulties in terms of budget because how it works operation on the ground. You know, firefighters are much more aware of the risks. Absolutely fantastic. We need them to do that. What they then do is clean PPE more and need more sets of PPE. Now, a lot of services in the UK are into contracts if they don't own the PPE themselves that end at a certain period. So in Avon, ours is early 27, so we're stuck with 2 sets of PPE for every firefighter. We may need more than that. Now we know the new evidence that has come to light. So that is going to cost money and it puts a massive cost on either capital if you're going to purchase the PPE as a fire service or revenue if you're going to loan it and pay it that way. So finance as well.
Thank you. And Alberto?
Yes, I would say, I mean, local context is important, but I would say, you know, what has been echoed already in the room, that I think, you know, PPE is, can be challenging, you know, depending on the municipality's budget. But I think the importance of having proper fitting size PPE to limit vulnerability and gaps in the person. Everybody's made different sizes, different shapes, I think are very important. And I would just advocate that there are thoughtful and creative ways of looking at strategies for all these different types of issues. You know, and I'll just give a broad example. I know you can't compare countries, but in the United States, we have 1.1 million firefighters. 1.1 million firefighters, and 65% of those 1.1 million are volunteer firefighters that do not get paid for their volunteer work, particularly in rural municipality, you know, in rural geographic areas, and they make, you know, their PPE work with basic things. Sometimes it's hood swap programs to make sure that they're there. But I think, you know, having the importance of proper fitting gear and having it laundered is an important aspect of the discussion for today.
Thank you. So I'll come to you first thing, Alberto, on the supplementary there, which is, are there any innovations in practice you've seen that are working particularly well?
So I don't consider myself a PPE expert. There are some colleagues that are more, different personal protective equipment, but I will raise some observations over the years that I have seen work. It was raised before in our conversation this morning about the clean cab concept. So if you've ever, I encourage you to do ride-alongs with a firefighter. If you've ever not done it, it gives you some really interesting insight into, their workflow and how they move about their fire incident response. So sometimes firefighters will enter back into their fire truck with soiled gear, and that creates contamination, to the driver, operator, plus the people that are in the area. So the clean cab concept says, can we allocate a certain compartment within the truck to limit exposure of the gear until it's transported back to the station, and then for the third-party contractor to clean and launder. So, instilling a culture of, clean cab and making sure that gear is isolated before it's transported from the immediate fire scene is very important. I think preliminary exposure reduction is really important for gear. So when a firefighter immediately finishes response, is there a way to engage them in preliminary exposure reduction? If there are financial opportunities for second sets of gear, I would do that. Hood swap programs, like the part of the PPE that they wear around their neck. Sometimes they don't change it and they keep using the same one during a shift or for a long time, and it's not laundered. So we, have used hood swap programs in the States, which are effective at sort of reducing the contaminant that can, have dermal absorption on the neck. There's a lot of research now underway in understanding the effectiveness of different cleaning detergents that are being evaluated. So we're not sure that, but I'll defer to my other colleagues because, again, PPE is not my area of expertise.
Yeah, thank you for that. Just before I throw that one open to the panel, because I think you've just touched upon actually the next question on the list. I just want to stick with you for a moment, Alberto, which is what systems are in place to ensure that firefighters are not wearing contaminated PPE post-incident across the US, and how does this compare to what you've seen and heard about in the UK? I know you just touched upon a lot of that in your answer there, so I just wanted to see if you had anything further to add on that.
Yeah, so I embrace a philosophy called total worker health. So the philosophy says that, we look at both the employer and the employee as responsibility for addressing any type of change. So in the space of PPE and the fire service, I think about the multi-tier level, right? What is the organization responsible for, and sort of supporting a firefighter in their personal protective equipment, and then the personal accountability, of that person to make sure that they're using PPE. So I've seen in the States over the years that the company officers, right, the lieutenants and the captains that have oversight of their individual firefighters hold their firefighters accountable through, small policy. So standard operating procedures that say we're going to do these practices to launder and clean our PPE and limit secondary and tertiary transfer of carcinogen by doing these SOPs on scene and within the fire station, right? So, and simple things like not walking around with your dirty boots, right? Because you pick up particulate in the fire scene, and if you keep your boots on, you're transferring them all around in the kitchen, everywhere, your sleeping bunks. And so small P has that opportunity to help reduce some of that exposure. And then at the organizational level, it's what the, fire company or the fire brigade can offer their individual firefighters, like, how engaged are you with the vendor in laundering? Sometimes they forget what second sets of gear can be provided, what, different cleaning opportunities are there for gear, keeping gear in a different, talking about built environment, right? If you think about the workflow, if you've ever been in surgery and operated on a person, right? Like the place where the healthcare team changes and cleans their clothes is completely separate from the operating room. So we don't want, gear to move in different compartments within the fire station. So the organization can help delineate those areas where, gear should not go into this area, into the other. So in a big picture, I think about, what does the organization can do to help support the firefighter, and then what individual responsibilities and company officers can do to help the firefighter also, maintain and launder their gear.
Thank you for that. I'll just throw it open on the innovation point to the wider panel thing. Has anything they want to come in? Yeah, Anga?
I think there are quite few to watch. I would say probably the UK-based focus should be also about women in fire rescue service, because that's the highest amount of concerns in terms of the fitting of PPE for women. The other thing to interestingly watch is replacement of PPE, particularly gear, in terms of the new one, and if it contains PFAS or not, because obviously perfluorinated chemicals are also in the firefighter gear. So interestingly, watching US, particularly Massachusetts and Connecticut, they said that the firefighters' gear will not contain PFAS from 2027 to 2028. But what is coming to the light, interestingly, is that PFAS are sometimes replaced with the other chemicals, man-made chemicals, and the latest report, for example, shows replacement with brominated flame retardants, which are also not necessarily all of them really healthy. And the other one is the contamination methods. So Belgium, for example, is using for many years carbon dioxide. Obviously, there is not enough publications in that topic, but it seems that it might be more efficient than typical washing machines. Thank you.
Thank you. Luke, if I can come to you for my final question. Oh, I'll let you come in on this one first.
Oh, yeah, sorry if that's okay. I think it's really important. I think in terms of innovation, we've seen a sweeping change across the UK just through education and culture around how contaminants are managed on the incident ground, as Alberta mentioned, into the cab on the appliance and then back at station. So there's been a number of innovations. So what we want to do is try to keep the station as clean as possible when crews return from an incident. So what we're trying to do is manage that risk by zoning. Now, what we need to recognise that across the whole of the UK, the building stock for fire stations is predominantly really old. You know, talking 70s or earlier for most stations, most services across the UK. They haven't been built with contaminants in mind. So it's how we manage that flow of contaminants and that risk when we're back at stations. So that is going to take a considerable amount of capital investment to do, and there's no sort of funding formula for that UK-wide at this moment in time. So that's a significant risk in terms of our development of managing contaminants. We're innovating away from that in a small way at the moment in terms of trying to manage that risk. So when crews get back from incidents, a lot of services now have bins outside the station. So they put their dirty bagged up PPE into a bin, which is then collected by the laundry company. So it's not even allowed onto stations. So I think that's really important to recognise that innovation, but also the need for capital investment.
Thank you. Look, actually, that fits nicely into the final question, which is what are the key challenges in enforcing effective PPE cleaning standards, especially under the new British standards introduced recently?
Yeah, so I think from a FRS perspective, we need to get this new PPE contract out. It's going to be slightly different. There are new ISO standards that have been developed through this process, so that's going to be good. I think it's down to each service to understand whether they want to procure their own PPE or do a lease type system, and then how often they need it laundered, because the culture and the education is going into it. Crews are understanding they may need to wash their PPE more, but then at times that could leave you with a lack of PPE in certain areas. So the capital investment or revenue investment needed to buy a number of sets of PPE could be challenging.
Thank you. That's me finished, Chair.
Thank you very much. Assembly Member Bukhari.
Thank you. I'm going to go back to Luke with my question. It's again related to the removal of contaminated PPE and particularly after incidents. Would you say that there is an argument that firefighters are delaying it just because of the lack of facilities and fire stations themselves, and that's causing a problem as well?
No, I have no evidence at all to suggest that. I think what we've got is an issue of we have level 1 commanders, so a leading firefighter or a crew manager or a watch manager or a sub-officer, how they manage that contaminant risk on scene without a higher officer in attendance. So we don't know what goes unseen at times and how they manage it. So I'll give an example in Avon that we at times send an assurance officer out to identify any learning from the management of contaminants on the incident ground. So I think what goes on behind closed doors and we can't see is around education and changing that culture. So we need to do a little bit more around education and culture, I think.
And we've heard a lot about the awareness campaigns that's happening in America. There's been something similar in the Avon Fire and Rescue Service about PPE and decontamination. Has that been a success? For what kind of improvements have you seen in behavioural changes from firefighters because of that?
Yeah, I just wouldn't attribute this to Avon Fire and Rescue. To be honest, I would attribute this to work going across a number of, well, the vast majority of fire and rescue services across the UK. However, what we're all doing is our own piece of work on it until the NFCC push out their national guidance. So I think in Avon, we've seen a considerable change in culture and behaviour. Actually, there's a real good recognition of the risk now, and that's done through education. So whereas Alberto mentioned earlier, firefighters in the US before they joined do a 4-hour piece of learning prior to joining the service. In Avon, we include education on every single training school. So we have a session on the risks. And actually a really interesting point to raise here is, we have people across the service with all different lengths of time in terms of how long they've served. What we're actually finding is that people who have joined most recently in the last few years are driving that culture change with the people who've been in longest, who are sort of sometimes reticent to take on and change that culture and their behaviours. So that's a really interesting thing that we've identified.
Do you think that the London Fire Brigade should be doing more, though, on terms of making it a more of a wider scale awareness campaign? We've heard not just about decontamination, but also just general health and maybe, going into that area as well. Is there something more that we could be doing to make sure that the London Fire Brigade is just taking more of an initiative and awareness campaigns within its own institution?
I'm not fully aware of everything that London Fire Brigade are carrying out in terms of health and wellbeing with their firefighters. What I can tell you is I know they are working on reducing the risk to as low as reasonably practicable, and that they're actually putting a lot of effort into that, but I can't give you exact specifics of what they're doing and the outcomes.
Okay, and Luke, just another one for you about the wider picture in terms of health, because it's not just the firefighters that would be impacted by decontamination, and the risks go wider to the family members, people in their homes. What kind of discussions have been happening about how to make sure that they're aware as well?
Yeah, that's part of the education package we push out, certainly in Avon, and it's part of the wider learning from the NFCC in terms of the 7 training modules that we're going to be delivering. So I think the concept is to reduce risk. So firefighters leave a fire station with no contamination risk at all. So they've done all their cleaning before they get back into their vehicle or take it home with them. So I think that's the point we need to get to.
And I'd be interested to know if any of our academics here have kind of looked into whether the studies are going into those areas of family members being impacted. It does make me think, you're going home and you could be risking your family members, with the what you're wearing and the fact that you haven't cleaned properly. Is that something that either of you have been looking into as well?
There is quite a number of the studies coming from US, and probably I will give it back to Professor Kevin Martinez to discuss that, because I will be probably quoting his papers. But generally, we didn't do that in the UK. We're aware of that. We are aware that there are generations of the firefighting very commonly reported in our registry. And we also got family history as well, going from kind of grandparents to children in relation to the diseases and cancers. It is too early to speculate because the data is not analysed, but in terms of the current existing research, there is not much done.
Thank you very much. Luke, finally, if I can come to you. So following the withdrawal of the decall process for Dear Chief Officer letter by FRS from 1st of January 2026, what further work or campaigns are you undertaking to ensure fire and rescue services are taking necessary steps to keep firefighters safe?
Yeah, so I think that was an interesting letter that was probably released earlier this year, maybe February or March this year. And that was from the decall letter back in 2004, I believe, which was an exemption for fire services to face fit for breathing apparatus wearing. That has now been withdrawn as of the 1st of January 2026. So the NFCC notified all fire and rescue services around the UK of that letter. That's gone out, and I know fire and rescue services are managing that risk now and putting it in process to ensure that firefighters are tested initially for face fit on breathing apparatus and other respiratory devices like half mask respirators, and that's going to be rolled out at this moment in time.
Thank you.
On a frequent basis of retesting.
Sorry, there was a lag then. What more needs to be done to make sure that firefighters are wearing the correct breathing apparatus?
I think we have well-versed guidance in the UK around when firefighters should wear it. I think it still comes down to education and guidance, and then assuring ourselves that firefighters are doing it on the incident ground. So I think the piece of work that we're hoping to deliver in terms of national guidance will hopefully contribute to closing that gap if there is one. And then the other work packages we've got in terms of managing the deliverables of the 9 other work packages, I think they will considerably help to close that gap in when firefighters understand and can educate themselves on when to wear a breathing apparatus.
Thank you. And
if
Joanna,
they're still reluctant to do so. Yeah.
Thank you. Joanna, if I can come to you, what more needs to be done to make sure that breathing apparatus is correct and being worn?
Yeah, I mean, I'm not an expert on this, so I can't really comment. I do think, as Professor Steck said, women need to be taken into consideration because I think historically it's been expected that they'll wear the men's clothing, yeah, the other thing I just want to, on slightly separate, is that I know that London Fire Brigade have got a health and wellbeing team. So I talked about occupational health, but they also have a health and wellbeing team who do a lot of education and are working in this area. But I don't know exactly what they're doing, but they do have a specific team. I won't say any more about BA though.
I appreciate it. And the issue of women's uniform and PPE has come up on this committee over and over again, so a point well made. I think we're near to the end of the meeting there, just checking no one wants to say anything else that's not been said. In that case, I'll say a huge thank you to all of our guests. That was a really interesting and deep dive into contamination, so thank you very much for coming and contributing. We have a few short items of business before we conclude. Can we note the report and today's discussion? Can we also delegate authority to me as chair in consultation with party group lead members to agree any output from the discussion? Thanks. Can the committee note its work programme? The next meeting of the committee is scheduled for 2nd of December 2025 at 10 a.m. in the chamber at City Hall. No other urgent business. I now declare this meeting to be closed. Thank you.